Good day to everyone. I'll be delivering to you this video lecture on critically appraising an article on therapy. Now, if you'd go back to your syllabus, you will notice the heading Clinical Decision Making 2 indicated before critical appraisal. I will actually be interspersing and incorporating the different contents under clinical decision making throughout my discussion on critical appraisal on therapy. Those contents being the concept of randomization, intention to treat, failure rates, blinding, and the various measures of treatment effect. Now for the objectives. At the end of this session, the student should be able to construct both research and clinical questions in relation to a particular clinical scenario necessitating appraisal of recent medical literature, understand the concepts of randomization and blinding in clinical trials, interpret the various measures of treatment effect. Now for dichotomous outcomes, those measures include risk ratio, relative risk reduction or RRR, absolute risk reduction or ARR, and hazard ratio. Now for continuous outcomes, that measure would be the mean difference. These measures also include NNT or number needed to treat and NNH or number needed to harm. The next objective is to know the difference between per protocol analysis and intention to treat analysis. And lastly, to perform critical appraisal of an actual journal article of therapy, which will occur during the workshop. And by that we mean appraisal of the directness, validity, results, and applicability of that article, as well as individualizing the results of that article to your own patient. Now, as I mentioned in the orientation video, I highly recommend that you read the corresponding chapters and the references I've listed in the course syllabus. Now, there are only 2 of them. Now, Painless Evidence-Based Medicine by Dance et al. Is easier to read. Now, if you want a more comprehensive discussion on the different steps in critical appraisal, you can read the corresponding chapter on therapy in the reference on the right, authored by Gurdon Guyot. Now, in your clinical practice in the future, you will find yourselves in certain situations or scenarios where you may have questions regarding the efficacy of a novel or investigational therapy to treat a particular clinical condition. In such instances, you will need to look up both landmark clinical trials and the most recent literature about this new or investigational treatment to be able to answer if this treatment is appropriate for your patient. But of course, you have to know specifically what to look for first regarding this new treatment. What I mean is that you have to first construct a clinical question inspired by the clinical scenario you are in. For that, I will again refer you to the PICO-PECO model that has already been discussed previously. Since we are dealing with treatments or therapies, we default to PICO instead of PECO. You will see why in a bit. P stands for the patient population with a disease of interest or condition you're currently treating, for which there's this new, recently approved or investigational treatment. Naturally, this treatment would fall under I or intervention. And of course, when it comes to experiments or clinical trials that were performed to test this treatment, we would not know if this investigational treatment was of any beneficial effect or not on the population that was treated if we don't have a comparison group. Now, that comparison group could be a placebo group, meaning a group receiving a dummy treatment or pill that does not have any therapeutic effects whatsoever. This is appropriate when there is no currently accepted treatment yet for a particular illness. You could also have a comparison group that receives the currently accepted standard of care for the disease if such already exists. In such cases, investigators want to see if the investigational therapy is just as good or is better than the current standard of care. Now, mind you, performing a clinical trial for an investigational drug or treatment using a placebo group is highly unethical if there is already an accepted or proven standard of care existing for the condition the investigational drug is intended to treat. Lastly, you also have to specify in your clinical question what your outcome or outcomes of interest are, that the treatment is intended to treat or prevent. Depending on the situation, that outcome may be something positive such as cure or prevention of recurrence or sequelae, or it could be something negative such as occurrence of death or disability. Perhaps it is best that I give you a couple of examples to help you understand how the PICO model works, and how you can use it to construct a clinical question appropriate for the clinical scenario you find yourself in with your patients. Here are the different components of the PICO model, and I have already defined them for you here in this table. Let us say your clinical scenario involves a young pediatric patient, a toddler to be exact, who has had frequent bouts of non-infectious acute diarrhea. You vaguely remember from a conference that zinc deficiency could be one possible etiology for this. However, you're not quite sure about the data regarding zinc supplementation to prevent diarrheal disease, and that you may need to appraise the data first before supplementing zinc to your patient. Thus, the clinical question you must construct for your appraisal would be, among children between the ages of 1 and 5 years suffering from diarrheal diseases, how effective is zinc supplementation, the intervention you have in mind, compared to placebo or no zinc supplementation for that matter, in preventing acute diarrhea? With that, you would now know what journal articles to look for that can help you answer this particular clinical question of yours to help your patient. Here's another example. Suppose in your clinic, you have an adult, non-diabetic obese patient who is trying their hardest to lose weight. He or she has been quite compliant with the prescribed diet and is doing their best to exercise often, but still could not get to the recommended weight loss target or goal. You made it a point to click like or to follow journal articles such as JAMA or New England Journal on various social media platforms. You could vaguely remember one time while browsing one social media platform you frequent that there is a recently approved diabetes medication, a GLP-1 receptor antagonist called liraglutide, that has been used in non-diabetics to produce clinically significant and sustained weight loss combined with lifestyle counseling. However, you want to know more about this before going ahead and prescribing this to your patient. Your clinical question now goes as follows. Among obese non-diabetic patients, how effective is regular use of subcutaneous liraglutide compared to placebo in reducing body weight by, let's say, 5 to 10%? Now, with these couple of examples, I hope you are now ready in constructing the clinical question in relation to the clinical scenario you will be presented with during the workshop. Now, the particular study design that very much monopolizes articles on therapy is the Randomized Controlled Trial Design, or RCT. In this design, you basically recruit patients from a particular population that satisfy a set of inclusion criteria that is typically based on the disease or condition being treated, or risk factors for a certain disease if the RCT is about an intervention that is hoped to prevent said disease. Next, the process of randomization is applied. Randomization is defined as the process of assigning participants to treatments and control groups, assuming that each participant has an equal chance of being assigned to any group. The researcher is not the one assigning which treatment group a study participant has to go to, but instead leaves it to some random event to make that decision for them. In the olden times, they probably relied on coin toss for that. Which side the coin would fall on is that random event that helped decide which treatment group one would be assigned to. Of course, nowadays, we rely on computer software to do the randomization for us. Of note, British English spells the word randomization with an S instead of a Z. Afterwards, these study participants are followed for a particular time period, called the follow-up period, to see if the outcome of interest has occurred or not by the end of the said follow-up period. Now, when reading a published RCT, you have to be wary of the type of RCT that was implemented in the experiment or clinical trial, and we base this according to the study objective. This is frequently indicated in the methodology section of the paper, or in the introduction where the researchers would usually state their study objectives. If it is not mentioned explicitly, you will need to pay attention to the conduct of the study itself. As clinicians, there are 3 types of RCTs that you have to be aware of. First is the superiority trial. This type of trial is used when the objective is to prove that the investigational treatment is better than or superior to the control, which is very frequently the current standard of care. If the researcher's objective is to demonstrate that the new or investigational treatment is clinically just as good or equivalent to the control or current standard of care, an equivalence type of RCT is performed. Lastly, with non-inferiority trials, the researchers aim to show that the new or investigational treatment is not much worse than standard therapy. Now, one good reason why we need to make the distinction is that there are some differences in the way interpretation of results are made. Let us now begin with the appraisal process. As a quick preface, articles on therapy are probably the most common type of articles that you will come across as you start your medical careers. For that matter, there is quite a lot of material to be covered in this video because of that. Just as with critical appraisal of articles on diagnostics, we follow the same sequence. We start off with appraising directness, because if the research question posed by the article is not at all matching or jiving with your clinical question, then the subsequent steps will just be a waste of time. Now, the main question regarding directness of a study or article with the clinical scenario you are in is, does the study provide a direct enough answer to your clinical question in terms of type of patients, intervention, comparison group, and outcome? What you are basically doing when appraising directness is comparing your clinical question from your clinical scenario with the research question posed by the article and deciding whether or not the article or articles you have retrieved would have the answers to your clinical question. Now let's go back to the obese patient from earlier and use the clinical situation as an example. The clinical scenario is you have a 28-year-old obese female with a BMI of 31.22 and without any history or diagnosis of diabetes mellitus. Despite non-pharmacologic measures to lose weight, she is having a very hard time attaining the recommended weight loss goals. Her endocrinologist is considering putting her on subcutaneous liraglutide, a GLP-1 receptor antagonist, at a dose of 3 mg once a day. She is very interested in this suggested treatment, but it won't be till next week when she sees her endocrinologist again. Because of that, she asks for your opinion. Would you recommend it or not? The clinical question that should start going through your head after this encounter is, among obese non-diabetic adults having difficulty losing weight despite non-pharmacologic measures, how effective is regular use of subcutaneous liraglutide compared to placebo in reducing body weight? Now, you tell your patient that you are not an endocrinologist as a disclaimer, but you would also want to answer her query about the medication. So you tell her that you will be doing a quick review of the literature and get back to her in a bit. After placing the appropriate search keywords in PubMed, you come up with this article by P. Sonyet et al. Entitled A Randomized Controlled Trial of 3 mg of Liraglutide in Weight Management, published in the New England Journal of Medicine on July 2015. After reading the introduction and the methodology, you find that the research question of the investigators is, among non-diabetic adults aged 18 years and above with stable body weight, how effective is once daily subcutaneous dosing of 3 mg liraglutide compared to placebo in reducing their body weight by at least 5% and more than 10% of their initial body weight? Now, looking at the four components of the PICO model for both questions, you see that they are very similar, practically even same. Now, in terms of directness, this article is appropriate for your clinical scenario. Let's now move on to appraising validity. Recall that the validity of a research study refers to how well the results among the study participants represent true findings among similar individuals outside the study. Now, there are guide questions that will help you decide if the results of an article or a study has this validity for your particular patient. The first question is, were patients randomly assigned to treatment groups? Now, earlier on, we talked about how randomization works. This random assignment of the recruited study participants onto the control and intervention arms is the best way to ensure that these two treatment groups are truly compatible. The process of randomization is perhaps the best way to equalize the measured and unmeasured characteristics of these two groups of study participants, in that the only thing that is different between these two groups is the type of treatment that was administered. That is, one group got the investigational treatment, while the other group got the placebo, or the current standard of care if there is any. Now, if researchers did not perform randomization and were allowed to decide which treatment to put the study participants into, it could happen that more patients with, let's say, poorer prognosis may end up being assigned to the placebo group rather than the treatment group. Now, this can falsely result in the investigational treatment being more beneficial in terms of survival than the placebo group, when in fact it may have no effect at all or may even be harmful, simply because those in the placebo group already have a higher chance of dying during the follow-up period to begin with. Now, here's a must-do when addressing this question. Look at the article's methodology to see if there are any explicit mention of keywords such as randomization, randomized, or randomly assigned. If there are, you can be assured that randomization or random assignment was performed in the study. The next question to answer under appraising validity is, was treatment allocation concealed? Now, in clinical trials, the random sequence by which we assign participants to treatment groups is referred to as the allocation sequence. It is not enough, however, that researchers generate a random allocation sequence. They must also take measures to ensure that the sequence is not altered by caregivers who unknowingly or knowingly tend to disturb it. These measures are called allocation concealment strategies. Now, examples of such strategies include placement of treatment assignments in sealed opaque envelopes, delegation of a third party with no interest in the results to assign treatment, and use of computers for treatment allocation. To ascertain allocation concealment, look for the following words or phrases in the methodology. The remote center could either be a computer or a person which the recruiting clinician must contact to obtain the patient treatment assignment. The word indistinguishable, on the other hand, refers to how the packages containing the medications are described. That is, the packaging or the appearance of both investigational treatment and placebo cannot be told apart because they look the same. The next question to answer is, were baseline characteristics of the study participants similar at the start of the trial? To state this question differently, are the treatment groups in the study comparable? As I mentioned earlier, randomization makes the treatment groups similar in terms of both measured and unmeasured characteristics. However, it is not perfect. As such, reviewing the baseline characteristics allows us to check how successful randomization and allocation concealment were. To do this, we compare the treatment and control group participants in terms of prognostic factors, or factors that could affect the outcome of the study. Now, such prognostic factors can be of clinical importance. It may turn out that when you are reading the article, one group may have worse prognostic factors than the other, making them appear sicker compared to the other group. Now, what should we do to address this question? Look at the table of baseline characteristics. This is typically table 1 of the article. Sometimes there's a column of p-values, which tells us whether the difference between treatment and control occurred by chance. P-values less than 0.05 are what are conventionally referred to as statistically significant. What you need to know as well is whether the difference between groups is big enough to affect the results by putting one group at a disadvantage. The next question now is, were patients blinded to treatment assignment? Now, when we talk about blinding in research, this means that study participants are prevented from knowing what treatment they are receiving. To ensure this, the treatments being compared must be made indistinguishable from each other. This is typically done by making the packaging the same, or having identical preparations for both groups, such as there's no way of telling the investigational treatment from placebo in terms of appearance. Now, of course, there will be instances wherein blinding is impossible, because even without telling the patient, he or she can identify which group they have been assigned to. This usually happens when the investigational therapy is a particular diet, or are certain physical maneuvers, or when the intervention is surgery. Now, be careful not to confuse blinding with allocation concealment. Allocation concealment occurs before the randomization process, while blinding occurs after. Now, why do we need to blind not just the participants, but frequently the investigators as well? This is because knowledge of the drug or therapy can influence the assessment of patients receiving them, particularly when assessment of the outcome of interest involves some degree of subjectivity, for example, assessment of symptoms. Similar to the previous question, the next question to address is, were caregivers blinded to treatment assignment as well? If the clinician has knowledge of the group assignment, this could influence how he or she would treat the patient. A clinician who knows his or her patient is on a placebo may worry about that patient not getting the intervention that could potentially be beneficial, and may decide to take better care of the patient, thus potentially altering study results. On the other hand, if the clinician knows that the patient is in the intervention arm, he or she may worry about the side effects, and would look after them in such a way that these side effects are prevented beforehand. As with the former, this can likewise potentially alter study results. The ways in which blinding of caregivers is ensured is virtually the same as with blinding of participants. Instances wherein blinding becomes difficult or impossible for participants is basically the same with caregivers. Besides the study participants and caregivers, are the outcome assessors blinded to the treatment assignment as well? Now, who are outcome assessors anyway? They are study personnel who are responsible for deciding how a patient responded to therapy. In other words, they ascertain whether the outcome of interest has occurred in each study participant or not. Now, this would be easy if the outcome is clear-cut and has a straightforward definition, such as death. There are only two possibilities in this case, that is, whether the patient is alive or dead at the end of the follow-up period. Now, this becomes a difficult job when outcome ascertainment involves a criteria that has some subjectivity component to it. Imagine how the questions these outcome assessors need to answer can become very tricky. Like, was this hospitalization a result of a drug side effect? Or did this patient die of a heart attack or pneumonia? Or is this rise in creatinine significant or not? Understand as well that because of this component of subjectivity, any decision the outcome assessor makes can be highly influenced by knowledge of treatment assignment. Thus, there is also the need to blind them as much as possible. Now, what do we do or what do we look for in the article? Look for statements indicating blinding in the methodology. Find out as well who is making the assessment for the outcome, whether it are the investigators themselves or an independent group of outcome assessors. Likewise, look for statements that describe strategies that withhold information regarding patient assignment. Now, this question is a bit complicated to answer, so do pay close attention. The question is, were all patients analyzed in the groups to which they were originally randomized? Now, despite the researchers' efforts to have patients or study participants comply with the clinical trial protocols, there will be those who will not adhere to an assigned treatment protocol. This may happen for many reasons. They might forget how to take a drug properly, they suffer intolerable side effects, or they refuse to go on with a clinical trial for no apparent reason. Because of this, the researchers are faced with a dilemma. Should data from these non-compliant participants be analyzed as if they have stayed in the original treatment group, or should they be excluded so that only compliant patients are included? Now, there are two reasons why the intention to treat analysis should be performed, or why the non-compliant patients should be analyzed in the original groups. First, a patient's ability to comply is considered part of the success or failure of the therapy or treatment being studied or given. Patients stop taking treatment when they don't feel well, or experiencing the side effects of a drug they are taking. Thus, excluding the non-compliant patients from the analysis can make a treatment appear better or safer than it actually is. Next, censoring or removing non-compliant patients from analysis may disturb the balance of baseline characteristics that was achieved by randomization. Opting for intention to treat analysis preserves this balance and provides the most valid results. There is a downside to using intention to treat analysis though. When studying adverse effects, an intention to treat analysis may underestimate harm by including people who stopped taking the treatments and therefore have lower chance of experiencing adverse effects, unlike those participants who continue taking the drug. In such cases, a per-protocol analysis should be performed as well. Fortunately, many published RCTs would include both per-protocol and intention to treat analysis. In summary, it is best that both analyses be performed. Intention to treat analysis should always be performed because it yields the most valid results. On the other hand, per-protocol analysis should likewise be performed, particularly when patients want to know whether a drug can work, when we are interested in adverse events, and when studies attempt to prove equivalence or non-inferiority of the investigational treatment with the current standard of care. Usually, intention to treat and per-protocol analyses should yield more or less the same results. However, when the conclusions differ according to the analysis done, the results should be regarded with some doubt. Now, what do we need to look for in the article we are appraising? We need to read from the article that the investigators included non-compliant patients in the analysis. We look for any explicit mention of the term intention to treat, and this is usually under the analysis section of the methodology. If it was not stated explicitly, look for some indication that patients retained their original assignment even if they were non-compliant. Or better yet, check from the text whether the number of patients randomized is equal to the number of patients analyzed at the end of the study. This is usually indicated at the beginning of the results section of the article. Now, this is the last question under appraisal of validity. Was the rate of follow-up adequate? A word of warning though, we will be performing some math here, so best to have a calculator handy. Adequacy of follow-up refers to minimalization of the number of patients who drop out of a study. Let me first make it clear that study dropouts are not the same as non-compliant patients. While non-compliant patients may have stopped adhering to treatment protocols, we can still determine what happened to them as long as they stayed in the study and have not themselves dropped out. What dropouts do basically is that they leave the study and become lost to follow-up, leaving us with no data or knowledge of whether or not the outcome of interest was attained in these patients. And dropouts can occur with both compliant and non-compliant participants. Dropouts usually leave the study because of adverse effects of the investigational treatment or because of dissatisfaction. The greater the number of patients lost to follow-up, the more the study validity is threatened. To address this question, we need to look for explicit mention of dropouts in the article. That should be the minimum requirement in the manuscript itself. Dropout rates should be shown in diagrams that depict the flow of patients from recruitment all the way to the end of the study. Now, if that diagram cannot be found, check in the text whether the number of patients randomized is equal to the number of patients analyzed at the end of the study. Next, you have to find out if the dropout rate is large enough to affect the results of the study. With that, we will need to perform what is called a sensitivity analysis. Here is where we will be doing a bit of math. Now, to assess whether there are too many dropouts in a study, let us take, for instance, a hypothetical RCT. Let us suppose this RCT involves patients with disease X who are randomized to receive either an active treatment or placebo. The occurrence of death is the outcome of interest. Each treatment group had 30 patients randomly allocated to them. Now let us suppose in the treatment group there were 6 dropouts, while the control group had 7 dropouts. Naturally, that brings the number of patients analyzed to 24 in the treatment group and to 23 in the control group. Let us now suppose that in the treatment group, 5 patients died, while in the control group, 9 patients died. That would bring the death rates to 20.8% and 39.1% in the treatment group and control group respectively. Using the number of dropouts in each arm, we compute for the worst case and the best case scenarios. With the worst case scenario, we assume all dropouts in the treatment group and none in the control group attain the outcome of interest. In our case, the outcome is death. Taking this into consideration, the death rate in the treatment group now becomes 36.7%, while that in the control group becomes 30%. We set these figures aside first, as we will compare them with the best case scenario figures later. Now, in the best case scenario, we assume the opposite of that assumed in the worst case scenario. We assume that all the dropouts in the control group and none in the treatment group died. With that into consideration, the death rate in the control group shoots up to 53.3%, while that in the treatment group is 16.7%. What do we do now with this information? If the best case scenario shows fewer bad events for treatment, while the worst case scenario shows more bad events for the treatment, this means that there were too many dropouts in this hypothetical RCT, and this puts the validity of the results into question. Another way of looking at it is that when the conclusions differ in these scenarios, we say that the study conclusions are soft. Thus, if such occurs in the article you are praising, that article may not be useful after all in helping you solve your clinical quandary. On the other hand, if the conclusions remain the same, meaning both worst and best case scenarios show benefit or harm for that matter, we say that the study conclusions are robust. And we are done with appraising directness and validity. Let us now move on to appraising the results. There are only 2 questions to answer on the results appraisal, the first being, how large was the treatment effect? Before anything else, let us first define treatment effect. Treatment effect in RCTs refers to the numerical measure used to compare the effectiveness of the interventions. The magnitude of the treatment effect may be expressed by comparing outcomes in the intervention and control groups. Now, some outcomes are dichotomous, meaning there are only 2 possible results, for example, death or survival. Dichotomous outcomes are usually summarized as proportions, for example, the proportion that died in each treatment group. From here, we can derive the following treatment effect measures: relative risk reduction, and absolute risk reduction. We'll go through them in detail later. Now, besides proportions, dichotomous outcomes can also be expressed in terms of rates, and this entails a time component, oftentimes in terms of person years or patient years. From here, we can derive the hazards ratio. We have already covered hazard ratio last year under medical research 2. We will refresh our memories regarding this in this video. Now, outcomes can also be continuous in nature, meaning there is a wide range of possible results and are very commonly reported as values with decimals. Examples of those would be temperature or blood pressure, or numerical laboratory values even. Continuous outcomes are commonly summarized as means or averages. For example, the mean change in blood pressure in each treatment group. From there, we can derive the mean difference, which is how treatment effect is expressed for continuous outcomes. This is easily calculated by obtaining the mean result in the treatment and control groups and calculating the difference. Now, as I just mentioned, computing for the mean difference is quite easy, so I won't spend so much time on it anymore. What I will spend more time discussing on, though, would be the treatment effects for dichotomous outcomes. You have already covered them as early as in Medical Research 1, so I suggest you go back to your notes about these measures. Let us first start with relative risk, or RR. RR is equal to the proportion or rate of the outcome in the treatment group divided by the proportion or rate of the outcome in the control group. The outcome here is very frequently a negative one, such as death, disability, or disease recurrence, to name a few examples. Stated differently, RR is equal to the new risk for the negative outcome one will find themselves in if they receive the treatment, divided by the original or baseline risk for the negative outcome, which is that risk one has when he or she did not receive the treatment. We can abbreviate this new risk as R sub T and the original or baseline risk as R sub C. Now, if the treatment is effective in preventing you from obtaining the harmful outcome, you would expect the R sub T to be smaller than the R sub C. When the numerator is smaller than the denominator, you would expect the resulting quotient to be less than 1. In this sense, RR values less than 1 mean that the treatment is beneficial. Now, if the new treatment remains the same or unchanged from baseline risk after receiving the treatment, this would result in a fraction with a quotient of 1. Thus, RR values equal to 1 tell us that the intervention has no effect at all. For treatment effect measures that are fractions or ratios such as RR, the value of 1.0 is what is called the null value, or the value of no treatment effect. Now, if the risk of the negative outcome is higher after taking the treatment compared to the baseline risk wherein you did not receive a treatment, the numerator now becomes larger than the denominator, giving the quotient a value of more than 1. Thus, RR values more than 1 mean that the treatment is harmful, because it increases your risk of obtaining the negative outcome and thus is not recommended to be manufactured or marketed. Now, mind you, these are just point estimates, and we have not yet touched on the confidence intervals, which we will do later on. Let's now move on to relative risk reduction, or RRR, which is equal to the change in risk divided by the baseline risk. Recall the abbreviations we defined in the previous slide. Risk change is equal to the baseline risk minus a new risk. You then divide this difference by the baseline risk to get the RRR. Now, if the treatment is beneficial, we expect the new risk to be smaller than the baseline risk. Thus, the numerator of RRR will be a positive value. Dividing the numerator by the baseline risk will also give you a positive value. Thus, positive RRR values mean that a treatment is beneficial. Now, what if the treatment really has no effect whatsoever? You would expect the new risk to be just the same as the baseline risk. So when you subtract the new risk from the baseline risk, you get a value of 0. And 0 divided by the original or baseline risk will still give you a value of 0. Thus, RRR values equal to 0 mean that the treatment has no effect. Since we are dealing with differences here instead of ratios, 0 in this sense is now the null value, or the value of no effect. Lastly, if the treatment is harmful, you would expect the new risk to be higher than the baseline risk. Thus, the numerator of RRR is negative. Divide this negative value by the baseline risk and you still get a negative value. Thus, negative RRR values mean that the treatment is harmful. Now, there's another treatment effect measure that is just as important as the RR and the RRR, and that is the absolute risk reduction. Now, since the term used is absolute, the ARR is simply the difference between the baseline and the new risk. For that matter, since we are dealing with differences, the interpretation of ARR is basically the same as the interpretation of RRR. Take note again of 0 being the null value. What is important about ARR, however, is that we can derive two important measures from it. The first one is the number needed to treat, or the NNT, which is equal to the reciprocal of any positive ARR. Now, what does that number mean? The number needed to treat refers to the number of patients you need to treat with that new or investigational treatment in order to prevent one additional bad outcome. For example, the NNT is 6, and the outcome of interest that the new treatment is hoping to prevent, at least in the short term, is death. In this case, the NNT means that you first need to treat 6 patients with investigational treatment in order to prevent one death. In general, the smaller the NNT, the bigger the beneficial impact of the new treatment. Now, what if the ARR is negative? If you get its reciprocal, you get the number needed to harm. It is interpreted in the same way as NNT, only now, instead of prevention of the outcome, the interpretation now involves causing the outcome. So, an NNH of 6 means that when you treat 6 patients with a new drug, it will cause 1 new death among those you have treated. Now, the smaller the NNH, the bigger the negative impact of this new treatment. Now, just as a reminder, do not be confused with the null values. For measures that are ratios, such as the RR, the null value is 1. For measures that involve differences, such as the RRR and the ARR, the null value is 0. Now, in case you're still finding some difficulty interpreting the 3 treatment effect measures I just discussed these past several slides, try using the weight analogy. Let your weight represent your risk for the negative outcome. Let us say after intervention, which could be exercise or proper diet, your weight went down from 80 kilograms to 60 kilograms. 80 kilograms represents your baseline risk, while 60 kilograms represents your new risk. You can regard ARR like this. Your absolute reduction in weight is 20 kilograms, which is the difference between 80 kilograms and 60 kilograms. Let's then apply this analogy to relative risk. Divide your new weight by your baseline weight and you get 0.75. It is less than 1, thus the intervention is beneficial in reducing your weight, or your risk for that matter. It is like saying I now weigh only 75% of what I used to weigh. Stating this in terms of risk, the risk for the negative outcome is now only 75% or 3/4 of the baseline original risk. How about RRR? Applying the RRR formula, quantity of 80 minus 60 all divided by 80, we get the answer of 25%. This is like saying I lost 25% of my weight. The 20 kilograms which was lost from my original 80 kilograms is 25% of 80 kilograms. Stating it in terms of risk, the risk for the negative outcome decreases by 25% with administration of treatment. As a final word for this slide, notice that when you subtract RR from 1 or 100%, you get the RRR. Now, there are a few important things I need to point out about the RRR and the ARR. For that, I need to make use of this figure, which features the results of 2 hypothetical RCTs wherein the same treatment was compared to placebo, with the outcome being dichotomous and expressed in terms of event rate per 100 patients. The first RCT or trial 1 involved patients who are high risk for the outcome, while the second RCT or trial 2 involved patients who are low risk. Among high-risk patients in trial 1, the event rate in the placebo group is 40 per 100 patients, while the event rate in the treatment group is 30 per 100 patients. That gives us a relative risk of 0.75, indicating that the treatment is beneficial in reducing the risk for the outcome or event. The relative risk reduction is 25%, meaning the risk for the event is reduced by 25% if one receives a treatment. The absolute risk reduction is 10%. Now, let us look at the results among the low-risk patients in Trial 2. Here, the event rate in the placebo group is only 10%. Now, if the treatment is just as effective in these low-risk patients, meaning the RR is also 0.75, what event rate can we expect in the treatment group? The event rate in the treatment group would be 25% less than in the control group, or 7.5%. Double-checking this, the RR and the RRR are the same. However, take note that the absolute risk reduction for these low-risk patients is only 2.5%, even though the relative risk reduction is the same as for the high-risk patients. So what takeaway can we get from this? The relative risk reduction may appear stable between different populations, but the absolute risk reduction can vary from very low to very high. Although the relative risk reduction might be similar across different risk groups, though not always, the absolute gains, represented by the absolute risk reductions, are not. In summary, the ARR becomes smaller when the baseline risk or event rates are low, whereas the RRR, often regarded as quote-unquote efficacy of the treatment, often remains constant. Now, this is something to be mindful of because there may be some pharmaceutical companies that might advertise their drugs by mentioning only the RRR and conveniently omitting the ARR. If you give your patient this medication without knowing beforehand that your patient is of the low category risk, you will be doing them a disservice, as this entails expense and possibly risks since they are receiving a medication that they are most likely going to get little benefit from. Thus, in order for this to be meaningful, you as a clinician appraising the data should always determine from the article what the underlying incidence or baseline risk is, so that you could be able to properly assess the impact of such treatment on a particular population. On a similar note, if variations in RRR are noted between studies, it tells us that the treatment effect of a particular intervention varies across populations, and this can pose problems in terms of applicability of results. Lastly, we have demonstrated in the example previously that a large difference between RRR and the ARR occurs when the outcome is rare, that is, the baseline risk is low. Now recall from earlier that besides the three treatment effect measures that were already discussed, treatment effect can also be expressed in terms of hazard ratios, which is the measure of association widely used in survival analysis, which is something they should have already encountered last year in medical research too. You will encounter survival analysis again under critical appraisal of articles on prognosis. Now in survival analysis, there are two probabilities that are used to describe survival data. The first one is called survival probability, which is the probability that an individual survives from the time origin to a specified future time, which we designate as t. Now, even though it says survival probability, the event of interest may not always be death. It could also be disability, metastasis, or disease recurrence. So basically, what this probability really entails is a probability of not having the event of interest. The second probability to describe is hazard, which is the probability that an individual who is under observation at time t has an event at that time. This is where we base the hazard ratio on. This is an outcome measure similar to the prevalence ratio, the risk ratio, or the odds ratio, and this focuses on the event occurring. In survival analysis, we make use of Kaplan-Meier curves. Now, one type of such curve is the plot of the survival probability against time. The y-axis of the plot will be the proportion of the cohort still surviving, and the x-axis is time. Now, this curve provides a useful summary of the data that can be used to estimate important measures, those measures being median survival time and survival rates. I will show you how to derive them from the Kaplan-Meier curve in the next slide. So here's what a Kaplan-Meier curve looks like. This particular type of Kaplan-Meier curve uses survival probability or percent survival as a y-axis. Now obviously at the beginning of the RCT, everyone in the study is still alive. So the curve begins at a time equal to 0 for the x-axis and survival probability or percent survival equal to 100% for the y-axis. So as you move forward in time, you see that the survival probability decreases. Now let us start off with determining what the median survival is. Recall that the median denotes the middlemost value of an array of numerical data after arranging them from smallest to largest. So we project a horizontal line from the 0.5 mark on the y-axis until it touches the curve. From that point, drop a vertical line. Where this vertical line meets the x-axis, that is your median survival, which is expressed in terms of time. In this case, it is 6 months. Now, how do we determine survival rate at, say, 1 year? Locate the point on the x-axis corresponding to 1 year, which is in this case 12 months. Next, project a vertical line upwards until it meets touches the curve. And from that point, project a horizontal line towards the y-axis. You can see that it points at approximately the 0.30 mark. Thus, the 1 year survival rate in this case is 30%. Now, unlike the earlier Kaplan-Meier curve, this particular Kaplan-Meier curve is different in that it has event cumulative incidence rather than survival probability in the y-axis, which explains why the survival curves are trending upwards instead of downwards. Now, this type of Kaplan-Meier curve is appropriate when we want to present and explain the hazard ratio. Now, the data presented here is from a landmark RCT called the Jupiter Clinical Trial, which randomized apparently healthy adults without dyslipidemia but with moderately elevated C-reactive protein levels to receive either rosuvastatin, which is Crestor, or placebo. The outcome was occurrence of any cardiovascular event, and the follow-up period was 5 years. Now, there were 8,901 patients in each treatment arm. At the end of the follow-up period, there were a total of 31 events in the Crestor arm and 68 events in the placebo arm. This gives us a risk ratio of 0.46. Now, this translates to a relative risk reduction of 54%, which is quite impressive. However, if we would compute for the absolute risk reduction, we get a measly 0.4% because of the very low number of incident cases of cardiovascular events, showing that this population, which is composed of apparently healthy adults, is low risk. The computed hazard ratio, which is done by statistical software, is 0.46 as well, very much the same as a risk ratio, and represents the risk of cardiovascular events at any point in time during the follow-up period. Basically, you just need to know how to interpret the hazard ratio. No need to know how it is computed because it is quite complex, and it has to take into consideration the number of participants left in the study. As you can see here, with every yearly scheduled follow-up, we see lesser and lesser participants staying in the study. Now, we will be talking about the confidence interval in the context of critical appraisal soon, but do take note that the confidence interval for our hazard ratio does not contain the null value of 1, meaning that this hazard ratio is statistically significant, and we have the corresponding low p-value to support that. However, because of the apparent high number of losses to follow up, we should be a bit skeptical about this, though in all fairness, we have not done a sensitivity analysis here, which we can try doing on your own. Now, hazard ratios are very often interpreted the same way as one would interpret risk ratio, though the two are technically not the same. They actually have some subtle differences. When it comes to hazard ratio, it is regarded as one's risk of attaining the outcome of interest at any particular time in the course of the follow-up period. That's any point in time along the Kaplan-Meier curve. This is unlike the risk ratio, wherein the risk of attaining the outcome is in relation to the end of the follow-up period. It basically does not care about the timing of events, just the total number of events in the end. Like with the other measures of association and ratios, the null value is 1.0. You can pause this video for a while to go through the contents of this slide. Take note, however, that the clause "at any time during the follow-up period" is always mentioned in the interpretation, signifying that this is the hazard ratio we're talking about. Now, as you appraise articles that make use of survival analysis for their data, you will encounter a few statistical terms which you will need to at least understand what they represent, what they are for, and how to interpret them. No need to know the intricate details of how to compute for them. Now, one such term is a log rank test. This is a statistical test that compares two survival curves, typically one curve for the control group and one curve for the intervention group. You use this test to know if the survival curves in the two groups are the same, and that is basically our null hypothesis. If the p-value for the log rank test is above 0.05, this means you do not reject the null hypothesis and make the conclusion that the two survival curves are not statistically different. Now, if the p-value is less than 0.05, on the other hand, you reject the null and make the conclusion that the two survival curves are significantly different. Now, this test is widely used in clinical trials to establish the efficacy of a new treatment in comparison with a control treatment when the measurement is the time to event. When you appraise an article that uses survival analysis on their data, do pay attention to the results of the log rank test as well. Now, another term you should be familiar with is the Cox proportional hazards. So far, we have been dealing with the Kaplan-Meier curves, and we just finished discussing the log rank test. Now, basically, the kind of analysis done by both of these tests is what is pertained to as univariate analysis, meaning there's only one predictor or independent variable predicting an outcome. Now, Cox proportional hazards, however, allows for more than one predictor in the analysis, because of course in real life, we almost always have many factors or processes affecting how and when an outcome will occur. Now, Cox proportional hazards basically extend survival analysis methods to assess the effects of many risk factors on survival time simultaneously. We'll very quickly go through this again in the workshop. Now, when the journal article you are praising has more than one outcome, it is best that you construct a table with the first column listing their different outcomes, and the subsequent columns the pertinent or applicable treatment effect measures. Now, here is a sample of that table for dichotomous outcomes. Now, this table, on the other hand, will be the one to construct when you're dealing with continuous outcomes. Now, this will be the next and last question to answer under the appraisal of the results. Now, in the previous discussion, I have been presenting values for the different treatment effect measures. Now, these single values are but point estimates. Confidence intervals have to be reported. Let us take this statement for instance. Warfarin reduces the risk of stroke in patients with atrial fibrillation by 79%. Now, such statement does not accurately reflect uncertainty, and this is usually due to the sample size limitations. Thus, in addition to reporting the point estimate, which in this case is the RRR of 79%, an interval estimate that provides a range of possible values for RRR have to be reported as well. Now, this data on warfarin and stroke reduction came from a landmark 1992 clinical trial published in the New England Journal of Medicine. According to this article, the actual relative risk reduction could range anywhere from 52% to 90%. Seeing that this confidence interval does not include the null value of 0%, the RRR point estimate of 79% is said to be statistically significant. Now, I will talk about the importance of considering the confidence interval when looking at measures of association. Now, we have here the null value of 1.0, which is also the measure of no association, as you can recall from Medical Research 1. Now, in medicine, we also have to think of what is considered to be clinically relevant, and we usually set that at a certain point above the null value. Now, let's just say for this particular example, a risk ratio of 2.0 is what is clinically important to doctors or clinicians. Now, let us extend that boundary line like so. Now, let's look at the measure at the very top. We see that the point estimate is smack right in the middle of the null value of 1.0. Thus, this measure of association is not statistically significant because it overlaps the null value. And it is not clinically significant as well because the confidence interval is not reaching the 2.0 mark, which we previously designated as a clinically important measure. Now, for the next measure, the point estimate is above 1.0, but below the clinically important measure of 2.0. Now, notice as well that its confidence interval overlaps neither line. Now, this measure of association is thus statistically significant because its confidence interval does not overlap the null value line, but it is not clinically significant because the confidence interval did not reach or overlap the 2.0 mark. Now, for the next measure, we see a rather wide confidence interval. Perhaps the study had a small sample size and was thus imprecise. Now, we see as well that it overlaps both the null value line and the clinically important boundary. And with that, this measure of association is not statistically significant, but it could possibly be clinically significant. Now, more studies are therefore needed to get more evidence regarding this association, if there is any association at all. Now, for the next measure, we see that it overlaps only the clinically important boundary. Thus, this measure of association is statistically significant since its confidence interval does not overlap with 1.0. And it is possibly clinically significant since this confidence interval is still overlapping with the 2.0 mark. Now, for the last measure, we see that the point estimate is well above 2.0, meaning that there's a strong association and its confidence interval is not overlapping the clinically important boundary line anymore. Now, this measure of association is without a doubt statistically significant and definitely clinically significant. You will be seeing stuff like this again and again as you get to your clinical years, or at least in Medical Research 2 in the second semester. Mind you, being able to appraise medical literature is important so that you can be able to judge if a new treatment modality is appropriate for your patient or not. Now, that is a skill that you will eventually learn as you go forward in your higher years. Now, here are other important basic concepts to remember about confidence intervals. Let us suppose the event rate difference of +2 or -2 is what is considered as the clinically important measure or margin. When both ends of the confidence interval are on the side of the treatment being better, the treatment is definitely beneficial or superior. When both ends of the confidence interval are on the side of the control being better, the treatment is definitely harmful or inferior. When one end reflects important benefit and the other end reflects important harm, the study is inconclusive. Similarly, when one end reflects small unimportant benefit and the other end reflects small unimportant harm, the two treatments being compared are the same or equivalent. Finally, when one end reflects small unimportant harm and the other end reflects benefit, then the treatment is at least as good as or even better than the control, or in other words, non-inferior. And we're finally done with the arduous part of appraising the data. We're almost finished. The next order of business is assessing the applicability of the results. Now, one way is by checking whether the patient's characteristics satisfy the inclusion and exclusion criteria that were applied in the article. You can also look at the treatment effects in subgroups of patients that more closely approximate the individual patient we're treating. The results should present to you the findings of subgroup analysis. The limitation of this, though, is that in real life, there are too many patient subtypes, and subgroups in clinical trials are generally too small to address this issue. It is also helpful if you, as a clinician, have the prior knowledge and experience in treating the disease. Now, truly, there are various biological issues that can affect applicability of the results to our patient. And besides that, there are also socioeconomic issues to consider. In order to leave no stone unturned, Dance et al. In their book suggest using the SCRAPS mnemonic, which stand for the different factors that can potentially affect applicability of the results stated in the article. The very last part of the critical appraisal process involves individualizing the results of the article for your patient. Now, as clinicians, you try to gauge your patient's baseline risk to see whether the treatment you are intending to give him or her would result in a significant clinical impact or not. Basically, you estimate the benefits, risks, and costs of that treatment to your individual patient by assessing the patient's clinical risk as well as financial situation. Now, after applying and interpreting the relative and absolute risk reductions in the context of your patient, you ask yourself, are the likely treatment benefits worth the potential harm and cost of your patient? You also need to see if all clinically relevant outcomes have been considered, as far as your individual patient is concerned. Is the overall goal making the patient live longer or have them feel better? And most importantly, include your patient in all clinical decision making. And that is it for my extensive video lecture, which I'm very glad to have kept just under 1 hour. Thank you very much for sticking with me until the end. Here are my references, and see you in the upcoming workshop.